My name is Dr. Vinita Arota from Brigham and Women's Hospital and Harvard Medical School in Boston, Massachusetts. Welcome to this infographic-based educational activity designed to explore when and how to use basal insulin therapy in patients with type 2 diabetes mellitus. As part of this activity, we will review when to consider basal insulin therapy, discuss common barriers to insulin use, and practical approaches to overcome these barriers, navigate the currently approved basal insulins, and provide practical, evidence-based guidance for insulin titration.
The following podcast is part of a certified educational activity titled Putting Basal Insulin Therapy to Work for Patients with Type 2 Diabetes Mellitus. Access the entire activity and complete the post-test at peerview.com/HMF860. Downloadable infographics and additional resources are also available.
Which patients with type 2 diabetes should use basal insulin therapy? Recent guidelines from the American Diabetes Association suggest that injectable therapy can be used and should be considered if the A1C is above target despite dual or triple therapy. Now the question is, which injectable should be prioritized, basal insulin or a GLP-1 receptor agonist? Based on the recent guidance, which is based on a wealth of evidence from clinical trials, the recommendation is now to consider GLP-1 receptor agonists in most instances prior to insulin. This is based on the weight benefits as well as the low risk of hypoglycemia with this class of agents. This is a new recommendation, and so we will see this implemented over time. However, insulin is always an option in any patient with type 2 diabetes, and insulin should definitely be considered as the first injectable if the hemoglobin A1C is very high, for example, above 10%, or if there's symptoms or evidence of catabolism, and if there's evidence of significant beta cell insufficiency, or when type 1 diabetes is possible. Even for patients in whom the first injectable is GLP-1 receptor agonist, if the A1C remains above target, as it will in certain instances, at that point basal insulin can be added, and there are a lot of studies showing the complementary effect of basal insulin with the GLP-1 receptor agonist. In addition, there are now fixed ratio combinations of GLP-1 receptor agonists and insulin that can be considered. Insulin has the advantage of being effective at any glucose level and at any stage of the disease process. So there is clear consensus that there are a number of indications for when basal insulin therapy should be considered. A few of these include when the A1C is above the individualized goal on maximally tolerated non-insulin agents. In addition, insulin is indicated when there is evidence of metabolic decompensation, such as when the A1C is quite high, for example, an A1C above 9 or 10%, or when there's symptoms of hyperglycemia, such as polyuria, polydipsia, and weight loss. Insulin is also indicated if there's previous or current gestational diabetes or intolerance to non-insulin agents. In addition, a lot of experts believe that insulin should be considered in a patient newly diagnosed with type 2 diabetes and an A1C of 8.5% or higher. Insulin also has an advantage of being indicated and usable in patients with end organ failure or multiple comorbidities for which other agents may not be considered. In addition, we know that prolonged course of steroids can result in prolonged hyperglycemia, and insulin can be indicated there. Furthermore, given its safety and effectiveness, insulin can be considered anytime it is an appropriate option for your patient from diagnosis onwards. Although there are no contraindications for the use of insulin, there may be some patients who are less suitable for insulin therapy. For example, those patients who have limited physical and/or cognitive capacity who may not be able to self-manage insulin titration and manage it safely without a caregiver. In addition, patients who are older and asymptomatic with a shorter life expectancy may not be the best candidate for insulin therapy, as at this point, the balance of benefits and risks shifts with the shorter life expectancy. Is it possible to predict which patients may require insulin therapy faster than others? Studies have been done to look at this. Type 2 diabetes is a heterogeneous disease. Type 2 diabetes progresses at different rates in different people. In a large EHR study of over 5,000 patients followed over 15 years, what was found was that those who were diagnosed at a younger age had more rapid progression to insulin therapy. And we do see this clinically, where those diagnosed at a younger age seem to have a more aggressive phenotype. In addition, what has been seen is that those patients with very low BMI or high BMI also seem to progress more rapidly to requiring insulin therapy. This may reflect a state of lower beta cell function as well as very high insulin resistance. In the same EHR study, they looked at genetic risk factors and found that those with more genetic risk factors required insulin at a younger age. It is important to understand that type 2 diabetes is naturally progressive, and thus it can be expected that most patients at some point will require injectable therapy, including insulin therapy, to help achieve and maintain glycemic goals. It is important to discuss the possibility of insulin or injectable therapy early on and to do so positively and not use insulin as a threat. In addition, patients should not be treated as if they are at fault for needing insulin therapy. What does basal insulin do for patients? Basal insulin reduces the fasting blood glucose, addressing the basal needs of the body. Thus, what we see is a shift of the full 24-hour glucose profile downwards for the full day. While basal insulin shifts the whole profile down, it does not address the postprandial peaks, which occur after eating, and this can sometimes spill over and cause elevated fasting blood glucose. And so it is important in managing a patient with type 2 diabetes with insulin therapy to understand which particular times of day the basal insulin is targeting and when other therapies are needed to address the prandial needs. For example, in this study comparing two basal insulins, Glargine U300 compared to insulin degludec U100, we see that at baseline, the 8-point self-measured blood glucose profile is elevated throughout the entire day, with a range from about 170 milligrams per deciliter to 220 milligrams per deciliter, a difference of about 50 milligrams per deciliter. At the end of 24 weeks, we see that the entire profile shifts downwards, such that the new range is about 110 milligrams per deciliter to 170 milligrams per deciliter, and this happens similarly with both of the groups. And here the difference is about 60 milligrams per deciliter throughout the day. Note that the height of the post-meal peaks is about the same as before insulin initiation. Thus, what basal insulin has done here, it has reset the whole profile downwards, but has not addressed the peaks. Basal insulin therapy can only move the whole profile down. It does not flatten the peaks. It does not address the prandial insulin needs. What do we know about the long-term use of basal insulin therapy as well as its early use? We have insights from the ORIGIN study, which prospectively randomized and looked at over 12,000 patients with type 2 diabetes or prediabetes as evidenced by an impaired fasting glucose or impaired glucose tolerance, and followed these participants over 6 years. Participants were randomized to basal insulin glargine or to standard of care, which included oral therapies at the discretion of the investigators and providers. What we saw in the study is that over the 6 years, those assigned to basal insulin had better A1Cs, better fasting glucoses, less likely need to advance to dual and triple oral therapy compared to those in the standard group. In addition, effects on cardiovascular outcomes were neutral, and there were no cancer safety signals in this very large prospective randomized controlled trial. In addition, by the end of 6.2 years, about 11% of those in the standard of care group did advance to insulin therapy. So that gives us a sense of the natural history when insulin is used early on. It is effective, and it helps to maintain normal glycemia. Some experts believe that this early introduction of insulin therapy gives the beta cell some rest and may help preserve beta cell function later on. Also of interest in the ORIGIN study, in those without diabetes at randomization, those assigned to insulin glargine were 28% less likely to have diabetes develop at the end of the 6.2-year study. And this was sustained even in the 2.5 years of follow-up after the study. While hypoglycemia and weight gain were modestly more than the standard of care group, these results and results from other studies support the potential benefit of early insulin replacement therapy. What about the clinical and economic effects of insulin therapy in the real world? Here's a database study of over 71,000 patients with type 2 diabetes using data collected in 2011 showing what happens in the real world when insulin is started after 1, 2, or 3 or more oral agents are used. What was seen in this database study is that insulin was effective at any stage of disease after 1 oral agent, after 2 oral agents, or after 3 or more oral agents, but looked to be a little bit more effective with earlier introduction. In addition, hypoglycemia was not any significantly higher at 12 months, and in fact it was lower, though there was a slight increase in hypoglycemia at the 6-month mark. Furthermore, and quite intriguing, is that the total costs of healthcare actually decreased after the introduction of insulin therapy in all three groups. When this was further broken down, it looked like the main reduction in cost was in inpatient hospitalizations. Thus, we see here from a large real-world database study both the clinical and economic benefits of insulin introduction and therapy. Another concept that has surfaced in insulin management is this concept of clinical inertia or therapeutic inertia, in which advancement of treatment is indicated but is not done for whatever reason. There are a number of barriers that we'll go into, but the key message here is that time waits for no one, and that delaying intensification has been associated with increased cardiovascular risk. Shown here is a study by Paul et al. Looking at the hazard rate for cardiovascular events, and this looked at a composite of myocardial infarction, heart failure, stroke, as well as the individual components, and found that in those within the first year after diagnosis who remained with an A1C of 7% or higher and did not have any treatment intensification, there was a significantly higher risk of any of these cardiovascular events compared to those who did have treatment intensification and were able to achieve an A1C of less than or equal to 7%. To spell it out further, those who had an A1C of 7% or higher without treatment intensification in that 1 year had a hazard ratio of 1.64 for any cardiovascular event. In those with a history of cardiovascular disease, this hazard ratio was 1.57. When we loosened the targets and looked at it with an A1C of 7.5% or higher, again, these risks were significantly higher than in those who were able to achieve goals and did have treatment intensification with that 1 year. So delaying intensification has been associated with an increase in cardiovascular risk in database studies. Real-world studies have also helped us quantify to what extent insulin initiation is delayed, again referring to this concept of clinical or therapeutic inertia. Kunti et al. Demonstrated that insulin initiation is often delayed on the order of 6 to 7 years, even when it is indicated, as shown here looking at 3 separate cutoff points at an A1C of 7% or higher, an A1C of 7.5% or higher, or an A1C of 8% or higher, and transitioning from 1 oral antidiabetic agent or 2 oral antidiabetic agents or 3 oral antidiabetic agents to insulin therapy. The average time to initiation was 6 to 7 years. And in fact, other studies have also shown the same, in that the mean A1C at time of insulin initiation is often 9% or higher. So this is the number of years where patients are exposed to hyperglycemia and risk of complications which could be prevented. What are the barriers associated with insulin therapy that might be contributing to this clinical or therapeutic inertia? They can be categorized into 3 broad categories: patient barriers, provider barriers, and health system barriers. When we look at these barriers by the different categories, there is a degree of overlap because we all have similar responses when we think about insulin therapy, and yet many of these barriers are addressable. From a patient perspective, there's fear of hypoglycemia, fear of weight gain, a sense that these regimens might be complex or burdensome, and the term called psychological insulin resistance, where there's some reluctance to initiate insulin therapy. There may also be an element of anxiety or depression or even a sense of personal failure. From a provider perspective, there is also the very real concern and fear of hypoglycemia, which has been demonstrated in studies, but we do know with newer therapies that this risk is much less. There's also concern that the regimens that the patients are on might be burdensome or complex, and there may be an element of poor communication or inability to communicate all that is necessary within the time allotment of a clinic visit. From a system perspective, there are similar barriers: fear of hypoglycemia, communication needs, and the lack of time and resources for primary care providers to optimize insulin therapy. When we look at patient barriers of fear of hypoglycemia, weight gain, burdensome regimens, psychological insulin resistance, and anxiety and depression, we do now have a number of tools and evidence that suggests that these patient barriers can be overcome. Specifically, diabetes self-management education programs have been demonstrated to be effective and also help with lowering A1C. There's a lot of technology now in terms of mobile applications, titration worksheets, and guidelines that are at our disposal. In addition, the novel therapeutics in this area have advanced pretty remarkably, such that we now have agents that have a low risk of hypoglycemia and have a low risk of weight gain when used appropriately. In addition, it's important to recognize that the healthcare provider is not in this alone with the patient, and the patient is not in this alone with the healthcare provider. There are now extended teams, so the nurse specialist or the nurse practitioner specialist or the ancillary providers that can be there to support the insulin initiation and titration along the way. Furthermore, when we look at burdensome regimens, we do now have advances in technology with modern insulin pens, fixed ratio combination therapy, simpler titration algorithms, and once daily insulins that have more flexible dosing and lower day-to-day variability. So we have made significant progress in the tools that are available to help address these patient barriers. Let's consider some of the practical barriers to insulin use from a patient perspective. Immediately, a patient might fear the concept of a needle or injection. They also might feel that dealing with insulin is too complicated. There's also a real feeling for the patient that insulin therapy might represent some form of personal failure in their ability to manage their diabetes, and it is important to recognize this and to dispel this myth. There's also a belief that insulin causes complications. We've all heard the story where a patient says, "Oh no, I don't want to be on insulin. My aunt was put on insulin and she lost her leg." So it's important to explain that insulin is actually beneficial and helps prevent complications and reduces that burden of hyperglycemia. There may be concerns about low blood sugar or hypoglycemia, in other words, a blood glucose of less than 70 milligrams per deciliter, and there may also be concerns over weight gain. So, for example, with the fear of needle or injections, it is important to demonstrate the injection in the office, to show the pen, to show the small needle tips, and apply the concept of systematic desensitization to allow the patient get comfortable with the concept of insulin therapy and feel more comfortable in their own way. There's also a sense that the insulin therapy might be too complicated. And so for this, the provider can highlight that the injection is into the subcutaneous tissue, not into a vein, and together do a dry injection without any substance to observe and support the correct technique, and then administer the first medication in the clinic itself. In regards to feeling that insulin therapy represents a personal failure, it is important to explain and reassure the patient that insulin is an appropriate therapy from the time of diagnosis and that it is not a punishment. Throughout, insulin can be discussed in terms of its pros and cons, and throughout the course of care of a patient with type 2 diabetes, it is important to emphasize that type 2 diabetes is progressive and that insulin may be one of the therapies that will be used to help keep control over time. From a patient perspective that insulin might cause complications, it is important to reemphasize that insulin is a natural hormone and a replacement therapy. Recall that at the time of diagnosis, about 50% of beta cell function is already lost. So insulin is considered a replacement therapy for the insulin that the patients are no longer making. It is important to explain that most patients will eventually need insulin therapy or other injectable therapy, just based on what we know from the chronic progressive nature of type 2 diabetes, and that insulin helps achieve targets and therefore helps prevent and avoid complications. With concerns about hypoglycemia, it is important to emphasize that most hypoglycemia that has been seen with modern-day insulins is mild and can be self-treated, and that severe hypoglycemia is relatively uncommon. It is important to educate patients who are on insulin therapy on signs and symptoms of hypoglycemia and ensure that the patient and the care partners can recognize, treat, and avoid hypoglycemia. In addition, it's important to ensure comprehension of the self-adjustment and titration of insulin doses and to consider insulins and regimens that have lower rates of hypoglycemia. As mentioned, it is important to use systematic desensitization to allow the patients to get comfortable with the concept of insulin therapy and the blood glucose ranges that they are targeting. With concerns about weight gain, it is important to address weight in any patient with type 2 diabetes, and so this is an opportunity to encourage healthy weight and monitoring of weight during insulin initiation and titration. What can a healthcare provider do to help patients decide to try insulin therapy? We have data from the recently published EMOTION study, which was a survey study in 7 countries of patients who initially had reluctance in trying insulin therapy, but then did. And these were the top 10 factors that patients provided in the surveys that were helpful in trying to decide insulin therapy, walking me through the whole process of exactly how to take insulin, making it real and practical, and desensitizing them to the foreign concept of insulin, breaking it down to the step-by-step level. Second was encouraged me to contact office immediately with questions or problems, making sure to let the patient know that you're available. Third, showed me an insulin pen, was considered very helpful. Helped me see how simple it was to inject insulin. told me blood glucose numbers would improve after starting insulin, had me try injecting while I was in the office, showed me how small the actual needle was, reviewed blood glucose numbers with me, showing type 2 diabetes is not controlled and action is needed, showed me insulin injection isn't as painful as I thought it would be, again the concept of practical demonstration, and said insulin can help me live a longer, healthier life, again addressing its role in preventing and avoiding complications. In addition, the survey study found that there were 5 domains that healthcare providers could influence, and they are shown here. Healthcare providers demonstrated the injection process. This was considered the most helpful. The second was that the healthcare provider explained insulin benefits and then had a collaborative communication style and dispelled insulin myths. Another interesting factor was the authoritarian communication style. This was found the least helpful style, but did help about 54% of the patients. But as you can see, it was also associated with delayed initiation and at least 1 episode of insulin discontinuation. Of these 5 styles, the 3 that were considered the most helpful and, when embraced, encouraged insulin initiation and persistence were demonstrating the injection process, explaining insulin benefits, and having a collaborative communication style. Now, what do we mean by collaborative communication style? It's best to understand this when you look at black and white, so we'll pose authoritarian versus collaborative communication styles. An authoritarian communication style is like this. My healthcare provider warned me that he or she couldn't be responsible for what might happen if I didn't start insulin soon. My healthcare provider said he or she couldn't continue to treat me if I refused to start insulin. And repeatedly over many visits, my healthcare provider kept trying to convince me to start insulin. While these might be effective in the short term for some patients, this is felt to not be effective for the long term for the majority. What is recommended is more of a collaborative communication style. Examples shown here. My healthcare provider took the time to ask me about the reasons why I didn't want to take insulin. My healthcare provider encouraged me to try it for a while and see if it might help me feel better. This has been tried and been very successful, where you say to the patient, let's try it for a month, and if it doesn't seem to be working for you, then I'll help you get off of it. But let's give it a trial. My healthcare provider explained that the final decision to try insulin was mine, not his or hers. Again, this is the patient's disease, and we are there to help them take control and empower them in managing their disease process. My healthcare provider took time to answer all my questions and address my concerns about insulin. And my healthcare provider encouraged me to contact his or her office immediately if I ran into any problems or had questions after starting insulin. It's not one-and-done therapy. We are in it for the long run, so insulin therapy does require that partnership and availability and the resources of your office staff, for example, to be there for the patient during the initiation and titration phases. So which counseling approach do you think is more likely to result in persistence and adherence to treatment? Is it the scolding, the blaming, the shaming, or the encouragement, the supporting, and the empowering, as well as the skill sets and the tools in order to be able to do it? That's a rhetorical question. Clearly, it is the latter. Talking about insulin therapy as if it is a punishment for bad behavior may cause patients to delay timely initiation or to be non-adherent to insulin when other treatments are no longer effective. In the emotion study that was just reviewed, authoritarian statements by healthcare providers were mentioned by 54% of patients who started insulin, but they were also associated with delayed insulin initiation and periods of non-adherence. So be collaborative in the style, show how it can be done, and these are some of the things that patients have identified as very helpful. What about provider barriers associated with therapeutic inertia? These also include fear of hypoglycemia, the concept of burdensome insulin regimens, and poor communication or resources to allow the optimal communication. We do have resources available to us. In the clinic, nurse-led management, insulin initiation, and titration has been demonstrated to be very effective. They have time and resources that the individual provider may not have within the domain of the clinic visit. In addition, specialist feedback has been demonstrated to be helpful. Training is important, and agents are now available that have a low risk of hypoglycemia if insulin intensification is needed. In the area of burdensome regimens, again, we've had advances in the last couple decades with newer therapies that are simpler. We now have fixed ratio combination therapies and simpler titration algorithms. With communication, it is important to have feedback with nurses and specialists and a team-based approach to care. Common contemporary barriers to insulin use from a clinical provider's perspective are highlighted here and include concerns about risk to the patients, concerns about risk of weight gain, hypoglycemia, impaired quality of life, assumptions about the patient inability to use insulin, assumptions about the patient refusal to use insulin, lack of resources including drug costs, availability of staff, time requirement, skills needed to support insulin initiation, and reluctance to use insulin early in the diagnosis of type 2 diabetes. But how can we overcome some of these common contemporary barriers to insulin use from the provider perspective? With regards to concerns about risk to patients, it is important to understand that there is a low risk of hypoglycemia and weight gain with earlier use of insulin in type 2 diabetes. And we saw this from the ORIGIN study, where the risk of hypoglycemia was low and the weight gain was about 1.6 kilograms over 6 years compared to the standard arm. In addition, with each successive generation of insulin therapy available, we have agents that have lower risk of hypoglycemia. Regarding assumptions about the inability of the patient to stick to and to embrace insulin therapy, it is important not to assume disinterest or non-adherence and to really embrace the conversation with the patients to discuss both benefit and risk, initiation versus inaction. Regarding assumptions about refusal, most people can manage insulin with appropriate education and support. It is important to tap into your local resources and tools, including diabetes self-management education programs and ancillary providers in your own clinic, including nurse specialists, nurse practitioners, as well as healthcare providers who may provide cognitive behavioral therapy and motivational communication to help support insulin initiation and titration. Regarding lack of resources, it is important to include family members, caregivers, in education and ongoing support, and consider getting support from qualified team members or the community. With regards to insulin initiation skills, there are now a number of toolkits and titration pages available on the web to help support insulin initiation and titration. For example, the Diabetes Canada Insulin Prescription Toolkit and the Diabetes Canada videos in the links below. With regards to reluctance to use insulin early, it is important to realize that delaying therapy actually prevents patients from achieving these targets and maintaining them, and that period of hyperglycemia during this delayed therapy does accrue to increased risk of complications. So if we summarize the practical steps that can be taken to overcome the common contemporary barriers to providers, it is important to recognize that we need to make the time to help patients understand the value and role of insulin therapy. Self-management requires education, which requires time. Shared decision-making is the standard of care, which also requires time. And again, it's important to utilize the tools within your own clinic, including your additional staff, to support insulin initiation and titration. Another important concept is that of collaboration, not only having a collaborative voice in your communication, but to collaborate with the patients and with the support circle within the clinic and within their own family to educate and train, and to refer to resources. There are prescribing aids and decision tools that can help with insulin initiation and titration. Looking at it from a system perspective with therapeutic inertia, many of the same factors apply here. Again, fear of hypoglycemia, the communication needs, as well as the lack of time and resources for primary care providers. And what we see, many of the solutions apply here as well, namely looking at nurse-led management of insulin initiation and titration, using agents with a low risk of hypoglycemia if insulin intensification is needed, as well as taking advantage of your specialists and getting specialist feedback and technology-based assistance. Therapeutic inertia is such a hot topic these days because we know that we have the tools to address hyperglycemia and minimize the risk of hyperglycemia and minimize the risk of long-term complications. It is such a hot topic that the American Diabetes Association recently held a summit on the topic, inviting and including stakeholders from multiple perspectives. And as shown here in the word cloud, these are the top contributors to therapeutic inertia. Time, feeling overwhelmed, cost, fear, education, apathy, and collaboration. And yet, these are some of the very same potential solutions to therapeutic inertia: time, education, collaboration, information, guidelines, access, data, support, knowledge. This is what it will take to help overcome the therapeutic inertia that has now been quantified and is clearly evident. So in summary, if patients with type 2 diabetes live long enough, they will probably need injectable therapy, of which insulin is one of the choices. Insulin therapy replaces the hormonal deficiency associated with progressive beta cell failure and can be considered at any point in the spectrum of care. Therefore, patients should not be treated as if they are at fault for needing insulin therapy. This is part and parcel of the disease course of type 2 diabetes. When it comes to insulin initiation, time is no one's friend. Delaying insulin exposes patients to more risk of diabetes complications and higher overall healthcare costs. And as we saw in the database study, introduction of insulin therapy was associated with reduction in healthcare costs. Education can overcome most barriers to insulin therapy, and there's different ways to give this education. Demonstration, being available, and collaborative communication are key for both clinicians as well as for patients. Encouraging, supporting, and empowering patients with self-management is associated with better clinical outcomes, lower overall healthcare costs, and higher adherence to therapy. So how should patients with type 2 diabetes use basal insulin therapy? In this section, we'll cover the general glycemic goals. What are the targets when we initiate insulin therapy? How to titrate? What is the initial dose? How do we titrate over time? What are the differences in the different basal insulins that we currently have available? Where to inject? It can be injected in the back of the upper arm, in the abdomen, but not the navel, the side of the upper thighs, or in the buttocks. And how to use some of the newer medications that are now available and how they might differ in some of the previous generations. So let's navigate the currently approved basal insulins. First, what are the glycemic goals that we should try to attain in most of our patients? These glycemic goals are generally recommended glycemic goals. The American Diabetes Association generally recommends an A1C goal of less than 7% for most patients with type 2 diabetes in order to prevent complications. The American Association of Clinical Endocrinologists recommends an A1C of less than or equal to 6.5%, given that this can be achieved safely. Fasting plasma glucose goals from the ADA are 80 to 130 milligrams per deciliter, and postprandial glucose goals of less than 180 milligrams per deciliter. For ACE, these goals are a little bit more stringent with a fasting plasma glucose goal of less than 110, again if this can be achieved safely without hypoglycemia, and a postprandial glucose goal of less than 140, with the recognition that normal glucoses without adverse consequences helps minimize the risk of long-term complications. It is important to note that not all patients benefit equally from these intensive targets, and that these are general goals for most people. Less stringent targets should be considered in patients with multiple comorbidities or limited life expectancy, and more stringent targets should be considered in those who are younger if they can be easily attained and safely attained, and in those with a newer diagnosis of type 2 diabetes for the goal of preventing long-term complications. It is also important to recognize that the A1C goals cannot be selected independently of the fasting plasma glucose goals and postprandial glucose goals. So it's not just one number. We do have to look at the whole patient and the whole profile. And to do that, we look at their glucoses throughout the day. Glycemic targets and treatment regimens must be individualized, and clinicians should be aware that both overtreatment and undertreatment have been reported in healthcare quality surveys, and that both overtreatment and undertreatment can be harmful. So individualization of treatment is key and is mandatory to assure patient safety. Let's look at the currently available basal insulins. There are currently 7 basal insulins approved in the United States. 2 human insulins, which have been available since the 1980s, NPH and regular human insulin, and 5 analog insulins. The first generation insulin analogs were introduced in the 2000s, and these included U100 glargine and U100 detamere, as well as U100 glargine follow-on. The next generation insulin analogs include U100 degludec, U200 degludec, and U300 glargine, and are the most recent additions to the class of basal insulins. Although these are all basal insulins, they do differ in terms of duration of action. If we look at our first basal insulin, NPH, this has variable duration of action and a duration of action that does not cover the full 24 hours. In fact, NPH insulin has a peak often at about 4 to 6 hours and lasts anywhere for about 10 to 16 hours, but it is really quite variable. The same is true for regular human insulin, which has a very variable duration of action. Our first generation basal insulin analogs, U100 detamere and U100 glargine, are less variable and had a little bit longer duration of action to allow once to twice daily dosing. And with the newest generation, U100 degludec, U200 degludec, and U300 glargine, we have less variability and a more protracted duration of action to allow once daily dosing. Here you see that the duration of action is about 30 to 40 hours, allowing a steady state. These basal insulins differ in their time to action as well as their duration of action. NPH, its onset time is about 1 to 2 hours and has a peak at about 4 to 6 hours, but is quite variable. It also requires resuspension, and so there's some variability if the resuspension doesn't occur appropriately. With detamere and U100 glargine, the duration of action is anywhere from 7 to about 24 hours, so this is dose-dependent and somewhat variable, but less variable than NPH. With the next-generation basal insulin analogs, U100 or U200 degludec and U300 glargine, we have a duration of action of about 30 to 40 hours for the two, but it takes anywhere from 3 to 5 days to reach that steady state, and that's important to recognize. If we look at each generation of basal insulin, we have had significant progress with each generation, such that we are close to matching the true ideal basal physiologic insulin. The true ideal physiologic insulin would be peakless, flat, and directly match the physiologic output throughout the day. With human insulins, U100 NPH and U500 regular human insulin, you see that there's definitely a peak and a dissipation within the day. And so there's the peak effect that we have to deal with, as well as a significant variability. With the first generation basal insulin analogs U100 detamere and U100 glargine, it's less of a peak and more protracted, but wanes by the end of the 24 hours. And with the new generation basal insulin analogs, U100 or U200 degludec and U300 glargine, we are virtually peakless with a protracted action and less variability to better match our ideal basal insulin. It is also important to look at day-to-day variability, as wide glycemic variability has been associated with a higher risk of hypoglycemia. Here we see with our first generation U100 NPH and U500 regular human insulin that this is quite variable in terms of effects within subject and between subjects. When we look at older basal analogs, U100 detamere and U100 glargine, there's less variability, and even less so with the new generation basal analogs, degludec and U300 glargine. If we look at the structure and mechanism of action of the basal insulin analogs, they differ significantly from each other, each of which has their own mechanism to slow the absorption and protract the mechanism of action. Insulin glargine, when administered, precipitates at physiologic pH, and thus causes slower absorption and a protracted mechanism of action. Insulin detamere has a fatty acid attachment, which causes it to self-associate and bind to albumin, which protracts its action. Insulin degludec also has a fatty diacid via glutamic acid spacer, which causes multihexamers to form and then dissociate, leading to its protraction of action. If we break down the mode of protraction, we see that this can account for some of the clinical differences that we see. So with NPH, there are crystal heaps under the skin that vary in shape and size and are broken down at variable rates, and this can contribute to variable absorption and clinical action. NPH requires at least twice daily dosing to cover the 24 hours and an understanding of when the peaks will occur and how to address those peaks. With insulin glargine U100, most patients can inject once daily, and it is less variable than NPH and has less nocturnal hypoglycemia than U100 NPH. With U100 detamere, many patients will require twice daily dosing, and here again, this is less variable action than NPH and has the benefit of less weight gain compared to U100 glargine, though similar risk of hypoglycemia as U100 glargine. With U100 or U200 degludec, this can be administered at any time of day and has the advantage of flexibility, is much less variable than U100 glargine, and reaches steady state in 3 days. Studies have also demonstrated less hypoglycemia than U100 glargine. With U300 glargine, higher doses are needed to attain the same glycemic effect as U100 glargine, and this is thought due to tissue proteases, which might decrease some of the bioavailability once underneath the skin. Like degludec, U300 glargine has less variability than U100 glargine and reaches steady state in less than 5 days. It also has less nocturnal hypoglycemia than U100 glargine. Now that we understand the differences in the structure and the protraction mechanisms with the basal insulins, how are they different clinically? Studies have shown that their clinical effectiveness at lowering A1C are fairly comparable. Here is shown a comparison via a Bayesian network analysis of 25 studies comparing different regimens of basal insulin in adults with type 1 diabetes. And as you can see here, the effectiveness in lowering A1C is quite similar. This is in type 1 diabetes, and we see similar results in patients with type 2 diabetes. What does seem to differ between the different insulins is the risk of hypoglycemia, particularly severe hypoglycemia, where the newer generation insulins seem to have less severe hypoglycemia compared to the older generations. And in addition, it seems to be safer to give the shorter actor basal insulins in split doses to help carry forward the basal needs throughout the day. And this may contribute to lowering the risk of severe hypoglycemia. It is important to note that severe hypoglycemia is now rare in contemporary clinical trials, especially with the newer insulins. From a patient level, are we able to understand the clinical and demographic characteristics that are associated with the high risk of severe hypoglycemia? And here is another database study from the Cleveland Clinic Health System looking at patients with type 2 diabetes, over 50,000 of them, from 2006 to 2015. And the factors associated with reduced risk of severe hypoglycemia were GLP-1 receptor agonist use, metformin use, DPP-4 inhibitor use, male sex, and BMI. And intuitively, the factors associated with increased risk of severe hypoglycemia included those with a history of non-severe hypoglycemia diagnosis. That was the highest odds ratio risk. Those who are on insulin therapy, black race, sulfonylurea use, a low A1C of less than 6%, cardiovascular disease, number of diabetes medications, heart failure, and the Charleston Comorbidity Index. So we can get a sense of patients who might be at higher risk of hypoglycemia, for which we might want to be a little bit more proactive in the therapies that we consider. What about the comparative effectiveness and safety of the different basal insulin analogs in patients with type 2 diabetes? When we look at the glucose-lowering effect, there's no substantial differences between U100 degludec, U100 detamir, U100 glargine, or U300 glargine. Insulin is insulin and can lower A1C. What is different is the risk of nocturnal hypoglycemia, with the newer basal insulins being associated with lower risk, specifically U100 degludec, U200 degludec, and U300 glargine. In addition, some insulins are associated with a lower risk of weight gain. And again, the type of weight gain that we're seeing in modern studies with the current insulins is modest, about 1 to 3 kilograms in some of the studies. The insulins associated with lower risk of weight gain, though, are U100 detamir and U300 glargine. It is important to recognize patients who might be at risk of hypoglycemia and to consider the different therapies that are available. The SWITCH-2 study was a double-blinded, treat-to-target crossover study in patients with type 2 diabetes with a risk factor for hypoglycemia, and this compared U100 degludec as the next-generation basal insulin to U100 glargine, and found that hypoglycemia, specifically overall symptomatic hypoglycemia, nocturnal symptomatic hypoglycemia, and severe hypoglycemia were all significantly less with U100 degludec compared to U100 glargine. In addition, as we've seen, day-to-day variability in blood glucose values is associated with the higher risk of hypoglycemia, and this was also shown in the SWITCH-2 study, in which higher day-to-day variability in the self-measured blood glucose values were associated with a higher risk of hypoglycemia, regardless of the type of insulin the patients used. Another open-label study in insulin-naive patients was conducted in patients who were not at high risk of hypoglycemia, and this compared both next-generation basal insulins, U300 glargine, compared to U100 degludec. And this study found more similarities than differences with the two insulins, although significantly less overall hypoglycemia in the first 12 weeks during the titration period with the U300. Over the 24 weeks, the A1Cs were similar, and the anytime hypoglycemia and nocturnal hypoglycemia were similar. What about NPH insulin? This was our first available basal insulin and still has a role. The benefits of NPH insulin are that it is available without prescription and it is the lowest cost basal insulin. However, there are some caveats and considerations one must make in terms of using NPH insulin. Specifically, NPH needs to be resuspended. This refers to the mixing of NPH thoroughly before injection to get more steady pharmacokinetic and pharmacodynamic effects, and that might include rolling the vial about 20 times for adequate resuspension. In addition, absorption may vary by the injection site, and it may not be suitable for patients at high risk of hypoglycemia because the peak action does vary from dose to dose, and because it does have a peak that the newer insulins do not. In addition, because of this peak, which we typically see at about 4 to 6 hours after NPH insulin administration, it may not be suitable for patients with erratic eating schedules because they must be able to plan in advance to match their meal times with the NPH administration. Now let's review some practical evidence-based guidance for insulin titration. First, a few concepts in basal insulin dosing. Very simply put, whatever you choose for the starting dose, it will be wrong. Let me explain. When we start insulin therapy, the starting dose is just the starting dose. It is important to incorporate this concept of anticipatory guidance in talking to patients, and that is to anticipate what steady state dose we want to aim for that we believe that they will need for adequate glucose management. Different guidelines recommend different things, but on a practical level, it might be easy to anticipate that the basal dose one might require is approximately 0.5 units per kilogram. And so it is important to say that up front, that the initial dose is just a starting dose, but that we have a goal to reach. The second important concept is that there is no maximal dose. Now, even though there is no maximal dose, there is a maximal effective dose, and that's important to be able to recognize when titrating patients to know when to start considering other agents. And lastly, we talked about therapeutic inertia. There's insulin initiation inertia, and then there's titration inertia, and both of which are important to address to make sure insulin management is optimized. How should basal insulin be initiated and titrated? Insulin is usually initiated at 10 to 20 units per day or 0.1 to 0.2 units per kilogram. This is according to the American Diabetes Association guidelines. Although there is no single correct way to titrate, it is important to recognize that patients can titrate insulin as safely and as effectively as clinicians do with appropriate training. Several algorithms have been evaluated, including the ADA algorithm and the INSIGHT algorithm. Different titration algorithms and approaches have been evaluated. Specifically, patient-directed titration has been compared to physician-directed titration. Here's a study that looked at 5 different titration algorithms, and the physicians preferred algorithm 2, which was increase 2 units every 3 days. A majority of the physicians preferred this, 93%, compared to only 9% of patients. When this algorithm was used, a fasting blood glucose of less than 126 milligrams per deciliter was reached in 10 days with just one hypo, and 81% of patients were adherent to it. Again, this was the physician-preferred algorithm. Interestingly, the patients preferred algorithm 1, which was similar to what has been reported in the INSIGHT clinical trial. This is a method of increasing 1 unit daily as long as the patients were not at goal, and this was preferred by 90.9% of patients, in contrast to only 5% of physicians. With this algorithm, the FBG goal of less than 126 milligrams per deciliter was reached in 8 days with no hypoglycemia. And more importantly, there was significantly higher adherence with the patient-directed algorithm. And patients liked this algorithm because it was simple, titrating in 1 unit increments felt safe, it didn't require extra math, and titrating daily might help them recognize and monitor their glucoses daily and help them get to goal quicker. With the newer generation basal insulin analogs, it is important to recognize that they do not reach steady state for several days, so these shouldn't be adjusted on a daily basis, but rather once or twice weekly. Here are the recommendations for titrating U100 or U200 degludec as well as U300 glargine. If the blood glucose is above target, insulin should be titrated once or twice weekly, with degludec by 2 units, with U300 glargine a range of 2 to 6 units depending on the blood sugars. If the blood glucose is at target, no change. If the blood glucose is below target, the dose should be decreased by 2 units, and some experts would say by 10% depending on the dose. It is important to recognize that even though there's no upper limit of basal insulin, there is a point at which basal insulin is no longer addressing just basal needs, and so it is important to recognize when to stop basal insulin titration. On average, this can be anywhere from about 0.5 units per kilogram to 1 unit per kilogram. Let me illustrate this. Here's what we can expect from 24 weeks of optimized basal insulin therapy. But if we decide to target, let's say, 130 milligrams per deciliter as a peak postprandial glucose level with the basal insulin, then what would happen? If we are too aggressive with the basal insulin therapy, this can cause the patients to become hypoglycemic in the middle of the night when they are not in a prandial state. And this is what happens when we increase the basal insulin dose beyond the needs of the patient. This is also termed over-basalization. With overbasalization, we do increase the risk of hypoglycemia, especially nocturnal hypoglycemia. What are the risks and burdens of medically attended hypoglycemia in patients with type 2 diabetes treated with basal insulin therapy? Studies have shown that hypoglycemia is associated with mortality risk, particularly in older adults. Hypoglycemia is associated with increased costs and can impact significantly adherence and persistence to therapy. What are some good clinical indicators when I should stop up-titrating basal insulin? One thing is to look at the profile, to look at the bedtime blood glucose, and then to look at the morning blood glucose, and to look at the difference. We call this the beam value, the bedtime-morning glucose differential. If the difference in the bedtime glucose and morning glucose is 45 to 55 milligrams per deciliter or greater, then that indicates that one should stop up-titrating the basal insulin and that other therapies should be used to better address the prandial hyperglycemia. One might ask, why not use a sliding scale insulin to adjust doses? And this is purely not physiological, it's outdated, and it can be harmful. Because, as shown with the roller coaster, we can't make insulin work backwards. It needs to be physiologically matched to the body's needs and proactively calculated. In addition, sliding scale insulin is an antique regimen for regular human insulin and is even less appropriate for basal insulin than it is for prandial insulin. And sliding scale insulin can be harmful, as suggested by the AAFP and the ADA. To summarize, we have general A1C goals for most of our patients to prevent complications of diabetes and hyperglycemia. In general, this A1C goal is less than 7% or less than 6.5% or lower if it can be achieved safely. It is important that these goals be individualized, as the same goals may not be appropriate for all patients, but these are general goals. When we look at the basal insulins we have available, all basal insulins are about equally effective in terms of A1C lowering, but they vary in their duration of action, mechanism of action, and clinical profiles with regards to hypoglycemia. It is important to recognize that basal insulin shifts the entire glucose profile lower, and thus, while it addresses basal needs, it cannot be used to flatten high postprandial peaks separately from its effects on fasting blood glucose levels. Careful titration is needed to avoid hypoglycemia with any insulin, and some basal insulins are less likely to cause hypoglycemia than others. In conclusion, with this activity, we have covered several dimensions of basal insulin therapy in type 2 diabetes. First, we reviewed when to consider basal insulin therapy. It is appropriate for any patient with type 2 diabetes, and there are certain circumstances where one would definitely consider basal insulin therapy. In addition, we discussed common barriers to insulin use and practical approaches to overcome these barriers. We learned about the term therapeutic inertia and how to overcome therapeutic inertia. We also navigated the currently approved basal insulins and understood that with each generation of basal insulin, we've approached a more physiologic insulin. And lastly, we provided practical, evidence-based guidance for insulin titration. Thank you.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/HMF860. This activity is supported by an educational grant from Novo Nordisk Incorporated.